Right, so as Richard suggested, this is a very brief citation. It was a citation that I provided when James was the recipient of the Down Surgical Prize. And so I haven't changed it too much, and I hope it gives good context and flavour to the James Brown we all know. So it is, and it's certainly an honour to deliver this citation, and it was awarded to Professor James Stephen Brown. And really, I hope that the brief words do justice to an individual and a career, both outstanding in equal measure. I've had the good fortune to have been trained by James, the pleasure to have worked with him as a colleague, although it was too briefly, and now the chance to regard him as a friend. James was the youngest of three brothers. He was born in Uganda in 1955. He started his schooling at Nakasero Primary School in Kampala, before the family moved to a farm on the Isle of Man 3 years later. James was dispatched to boarding school to the rather harsh environment of Llanellan School near Montrose, and then subsequently to the equally austere surroundings of Fettes College in Edinburgh, with its 350 acres, its rifle range, skating rink and golf course. In sport, Fettes' most notable alumni are on the rugby pitch, and it was on the wing for the first 15 that James too excelled. Indeed, such was his speed and prowess that he went on to represent Scottish schoolboys in the early 1970s. After a gap year at Michael House School in South Africa, James started his undergraduate career with a BDS from Edinburgh University, and then remained in Edinburgh as a houseman at the dental hospital. It was also there that he started going out with Sally, a modern languages student and younger sister of school friends. After an SHO job in Newcastle, a dental registrar role in Portsmouth, he attended Westminster Hospital Medical School, marrying Sally in his second year, a conjoint LRCP MRCS. The young maxillofacial surgeon Brown was a registrar in Sunderland in the late 1980s, gaining the FDS and the FRCS before moving to a senior registrar post in the West Midlands, by which point James and Sally had three young boys, Angus, Duncan and Hamish. James learnt his trade alongside contemporaries such as Bob Ord and Peter Ward Booth. Despite a heated civil war in Sri Lanka, James travelled to the Maharagama Cancer Institute just outside Colombo for a 3-month stint of, quote, tremendous experience with Tony Gabriel in early 1992. On returning, James was soon appointed as a consultant at Walton Hospital in Liverpool. It was a time of great change as our specialty began to evolve rapidly. Under the eye of James and colleagues like David Vaughan, regional centralisation of care was realised soon after in Liverpool. And now based within the regional oral and maxillofacial unit, James was pivotal in harnessing the opportunities that microvascular reconstruction offered patients, introducing several new procedures, none quite as impactful as the free iliac crest graft, or DCIA, for which James deserves considerable credit, proving its utility in both the mandible and in the midface. He travelled to many countries and continents, spreading his knowledge and outstanding surgical talents where he went. Whilst James trained a legion of successful oral and maxillofacial surgeons, undoubtedly leaving an indelible Liverpool mark on each one of them, it's, however, his impact on oral and maxillofacial research that really deserves specific credit. Indeed, the contribution of his academic career is somewhat difficult to underestimate. Gaining an MD from Birmingham University in 1994, he produced heavily cited evidence detailing patterns of disease in oral cancer, its behaviour and its outcomes, collaborating with Woolgar, Vaughan, Rogers, Shaw alike. More recently, James has produced essential classifications for both the midfacial and mandibular defects, each of which has been published in Lancet Oncology. Awarded a Hunterian Professorship in 2005 and an honorary chair from the University of Liverpool in 2010, James is responsible for the establishment and nurturing of arguably one of the strongest academic head and neck units worldwide. Amongst the large surgical team today, the Liverpool Head and Neck Centre boasts 5 clinical academic head and neck surgeons, alongside chairs in medical oncology and speech and language therapy. And it's James's vision that is responsible for driving forward multidisciplinary research that really truly can be considered bench to bedside and back again once again. To adequately summarise all of the other elements of the resume of James Brown is certainly no simple task. Needless to say, as chairman of the FRCS examiners, SAC member, regional training programme and clinical director, author, journal editor, and ultimately president of the British Association of Oral and Maxillofacial Surgeons in 2015, he's provided unique leadership and earned a well-deserved international profile within our specialty and beyond. As many of you will know, in late spring of 2015, James had a fall while cycling to work one morning, suffering an intracranial bleed. And despite a fairly dire prognosis, like a phoenix from the ashes, he made an amazing recovery, returning to work and reciting still the complete works of Simon and Garfunkel and Bob Dylan in the theatre. Now, the passing of time and recent retirement has led to several new threads to the brown bow. A talented painter, an ardent vegetarian, a competitively temperamental golfer, proud father to 3 very successful sons, and in the last year, a doting grandfather to young William. This represented the highest award that our association can confer, the Down Surgery Prize. And it's only awarded to those who are deemed to have made a major contribution to the oral and maxillofacial specialty in its widest sense throughout a consultant career. As I said on the day that he received the citation, to the president of the BOMS and the assembled colleagues, Professor James Brown is, was, and will continue to be clearly a worthy recipient of this prize. Thank you, Doctor.
Thank you for that introduction. I was gonna talk a little bit about my experiences and how what I've done, if you like. And so, in a sense, Andrew's done it for me. So I might go through some of those bits a little bit quicker. But I chose the title because of it's important to me that you can challenge and that you don't just believe what you hear, but you think about it and work it out and challenge it if you can, if you feel that it's strong enough to. I often think that I'm arrogant enough to think that I've got something important to say or intelligent to say. So you do need a little bit of arrogance, but at the same time, sometimes things worm away at you and you just think, I'm not going to let that go. I'm not going to let that go. And that's probably what drives my academic interest. I was going to say I was born in Kampala, so I can go through pretty quick. These are my 2 brothers, Archie and Andrew behind, with the headmaster and the second master going through Nakasero. This is just last year. We went back. And then my father left Africa as a mining engineer and bought a farm in the Isle of Man. And that was quite hard work and an education in itself. And then Lathalan. And I was going to show this picture because this is Mike Griffin here. I don't know if you can see my pointer, but that's Mike Griffin, who is president of the Royal College of Surgeons of Edinburgh and one of the best centres I played with. Fantastic. Just to point that out. And then I went to a gap year. I was going to teach because I wasn't very good at French, so I gave up my English and history, which I was good at, and did science, biology, physics, and chemistry. But I couldn't get the grades to study medicine, or didn't seem like a possibility at all. So in the end, I thought, well, I'll teach. I liked sport, and I thought I could do that. So I went to Michael House School in South Africa, and but I went off it a bit. I went off it a bit. So what did I learn? Rugby's violent, no doubt about it. That long distance running hurts, but unfortunately I was quite good at those sort of things. But anyway, teaching is a tough vocation, and farming, forget it. It's far too much like hard work, and you never make any money. So I came to Edinburgh University to study biological sciences, and with a view to become a teacher, but crikey, I didn't really think that I would do that. And then I thought, well, I have to do a PhD, and I didn't think I had the brains to do that. So I remember Vic MacDonald, a friend from school, a clever boy, did chemistry. He was at Edinburgh University as well, and he came and sat at the end of my bed and persuaded me to play rugby. And I was playing rugby for the Colts university team, and I met a couple of people doing dentistry and found out what their course was like, where they were working, and I was going to stay up at where the main university was, where all the pretty girls were and everything. And I thought, well, maybe I should do dentistry. And I finished my dental training. I hope it's going to work now. No, I'm going to have to click it. Sorry, it's not quite so neat. And then I did a house job, and I did my fellowship first part, 15% pass rate, but if you passed it, you were away. And so I went to the RVI and the General in Newcastle, and mainly drank alcohol in quantities, I seem to remember, although I was doing a 1 and 2. But I thought, well, maybe I could just be an oral surgeon. So although I had a place to go back to Edinburgh to study medicine, I took this registrar job in Portsmouth and went down there, and enjoyed that. And I remember I went to the autumn meeting. We used to have 2 meetings a year in our specialty. And the autumn, I think it was in London, and I met Ian Martin, and he just told me, you're mad, you've got to do medicine. And so I got a place at the Westminster for a shorter course, and they allowed me to sit first part of my LRCP MRCS. And so I went from being a registrar straight into being a clinical medical student, and finish in 3 years. And that was a fantastic advantage for me. I'm very grateful that I got that opportunity. And then did my housemanship in Roehampton, and really enjoyed that. And then when I went to Sunderland as a specialist, I had to be de-bushed, or that's what I think. I had to. I was no longer sort of at the forefront of medical and surgical care. So we were slightly it was a different game. But then I did plastics and general surgery as part of my training for the FRCS, and an important part of this time was going to Ohio State. So Peter Ward Booth arranged for me to exchange everything, cars, not wives, but just about everything else. And we went to Ohio State for 3 months. And I spent the time in the library mostly. And Larry Peterson, who's quite a famous, well-known surgeon at the time, had written a textbook, gave me his card. Of course, there was no internet. It was Index Medicus. And I used to go there and sit and drink coffee while they got me a load of publications, and I started reading. And I started finding out what the basis of our knowledge was, and it's a bit rickety in places, certainly. And I became interested. And then when we went to, I remember I went to see Bob Marks at Cleveland in Ohio, talking on his work on hyperbaric oxygen, and being very interested in all that. And I did the and you all the guys had to do, one of them had to do a presentation wherever we went, anywhere, to hear anything or do anything. So there was a lot more impetus to delivering and talking and lecturing, if you like. So that was a good experience, I thought. Sorry, I'm going to go back to this this one. And then, of course, I sat my FRCS and went to a senior registrar job in the West Midlands, which I enjoyed very much. Ken Lavery, who taught me how to sharp dissect. And I had a good time there. And I did my thesis, my MD thesis, on mandibular invasion, which was my own idea. And I'll tell you about that. And Peter Ward Booth's idea, which was what did high dose steroids do to the healing of a microvascular anastomosis? And I used a rabbit, an animal model, but I knew that the mandible was more interesting, and that's what I concentrated on for my MD. And I think that worked out very well for me. And I went to Maharagama to Tony Gabriel, and the idea was I was going to get some more specimens. But of course, I wanted early cancer, invading the jaw early to look at patterns of where the tumor entered the jaw. And of course, all those cases were treated locally. And it was only the really horribly big cases that ended up at the Maharagama Cancer Institute. So it didn't really work out, but I loved working with Tony Gabriel. Fantastic surgeon, fantastic guy, and really enjoyed my time there. And then I was appointed, and a young family, and here we are. My parents had come back from Malawi. They'd been out in 1975, 76 to Malawi, lived there since then, came back and lived on a longboat on the Bridgewater. which came through limb where we lived. And so on we went, and carried on working and finished my MD thesis. And of course, you know, Andrew Shaki has described how the unit has progressed. And because it was a regional unit was why I came to Liverpool. And I think we've shown that that's where the strength lies. So what did I do? Well, I'm not going to tell you how many operations I did because I have no idea how many operations I did, not a clue. And I thought when I became a surgeon and wanted to do cancer, I thought, well, actually, I'm probably only going to do about 1,500, maybe 2,000 operations. It's not very many. It's not going to show anything. So the number of surgeries that, obviously there's a duty of care, and patients really appreciate what you do for them. And it's a wonderful experience that. But counting, I didn't have my book and I wasn't very organized, and I didn't think it was that important really. And so I started off doing orthognathic cases, and this is David Vaughan and myself, when we had the tunable dye laser in those early days when he got me to do all that. And so it was a specialty really trying to make a way in the world in all sorts of ways. And David Vaughan was very much part of that. Number of neck dissections, no idea. And number of cancer resections, no idea. And this is a case of iliac crest, internal oblique muscle reconstruction of a mandibular anterior defect. And I show the case because I've got this picture post op of her with her grandchild. And it's so important. I read John Diamond's book on C, because cows get cancer too. Being alive is the most important thing. Being there, being in the world, watching perhaps your grandson, your grandchild. And that's happened to me. So this is my grandchild, and Angus is on the right, and Hamish, my other son, is on the left. And there's the generations. So that's what we live for in some ways. But what have I written now? You know, there's somebody that does work out what you've written, and that is Google Scholar. You can go to Google Scholar and you can find out how many citations your papers have. You can find out in some ways, what your influence is. So that's what I thought I'd talk about a little bit. And you can see that, and I'm mainly going to talk about myself as first author. I think that's very important, because a lot of those papers that I wrote as first author, I drove myself and wanted to write and was driven to write them. And hence they're important to me. So this is the first, during training, I did about 7 or 8 publications, and this is the one with David Barnard, which was the transnasal K-wire to fix the unstable cheekbone fracture. And of course, nowadays we use plates and we open it up and it's completely different. But in those days, there weren't that many options with plates, and people thought they got infected, and we wrote this paper on the K-wire. And I quite enjoyed being involved in that. And then an AV malformation. I did work on mini plates. That was the first presentation I gave at BAMS. And this paper on preserving the great auricular nerve in parotid surgery was Bob's, Bob Ord's thing. And I took on the writing and collecting the data for that. And you see there's a hydroxylapizide paper at the bottom, people will boo, but that was what I did during my training. And then when I became a consultant, I put what I'm going to discuss now, if I've got time, on maxilla, mandible, reconstruction in general, and some outcomes. And that's where my work has been. Andrew alluded to that earlier on, and I'm just going to talk about some of those areas as we go through. The maxilla, I really want to mention Steve Warlow and Martin Dedman and my time in Birmingham as so important, because it was Mike Wake's unit at the Queen Elizabeth Hospital, Birmingham. He was the only consultant in that particular department. And I spent a lot of time in the lab chatting to Martin and Steve, and they were incredible guys because they were bringing prosthetics into the implant era and leading it and doing fantastic work, really fantastic stuff. And they were great guys to be with. And so I learned an awful lot from them. And they went to the operating room, and Mike Wake was a really meticulous surgeon, perfect for implant work, and did it beautifully, but they told him exactly what they wanted. And Mike, he just did what he was told, really, in a sense. And that's really how you have to work with the person that's going to actually provide the prosthesis. Needs to be in control, pretty much control over any implant placement and where that is going to be placed and how it's going to work and everything else. So I learned a lot from that. And when I became a consultant, I thought, well, come on, we should be able to reconstruct these maxillary defects. And also when I was in Birmingham, if I've got time to talk about, I used to, as a senior registrar, I used to obturate a lot of the maxillectomies that were done by my ENT colleagues. And so they would do a maxillectomy and then there was no neck done or anything. And then it was just given to me. And I had to pick out all the bits of bone and clear it all up and take some impressions, and the patients were obturated and the results were not fantastic. And Steve and Martin used to talk to me and we discussed these things. And that's one of the reasons I started reconstructing the maxillectomy defect in particular. I think in terms of the mandible, it's more obvious you've got to reconstruct that. And I remember, yes, and then here's another case of this lady that I've just moved on from. She had a fantastic orbital prosthesis, and that was done by Martin and Steve because she got such a great overall result with her denture and everything. I sent her down to Birmingham to have them do that work. And this patient has an Amiloblastoma, a large Amiloblastoma in the maxilla, and required a big resection. And he got a great result with iliac crest, with titanium mesh to support the eye, but an excellent outcome, and implants and everything else in that sense. So we were able to really get people back to where they were. In the maxilla, I also published on what happens in the neck and whether we should do a neck dissection. And obviously for oral cavity type lesions that affect the upper jaw, then you have to think about a neck dissection just like you do in any other part of the oral cavity. And we managed to get some data together to show that to some extent, I think. And then the classification papers, this first one was written Head and Neck in 2000, and then Lancet asked me to write a review article on maxillary reconstruction, and so I updated the classification, and I'm glad I did. I think it was worth it. And 4 and 5, I added there's 1 to 4 for the maxilla, and then the 5 and the 6 for the eye and the nose, if the maxilla is undamaged. I think it was quite nice to add that. And those are heavily quoted 646 citations in both with both papers together. So that was more of a contribution than I thought it would be in the end, I suppose. And then in the mandible, I always thought, I think one of the things that we perhaps have to explain to some of our colleagues, oncologists, and maybe some of our ENTs as well, is that we were very much a peripheral specialty in head and neck cancer. We're not now, certainly not in Liverpool. And I think we owe a lot to Terry Jones and his team for the way that we work together. And both Richard Shaw, Andrew Shaggy, and our ENT colleagues, we get on so well. There's a lot of mutual respect, which is fantastic. And the quality of the research is across the board. And so we don't compete, we work together. And that's just wonderful. When I came to Liverpool, it was a war, I can assure you. And I remember speaking to one of my ENT colleagues, and Martin Shadlat, who ended up in Jersey, and I got into big trouble for them. But and of course I asked him to help me with a parotidectomy, but he just passed me on to Tristram Lesser. And so that's how things were in those days, but much better now. Fantastic. So I thought we should look at the mandible. It's our bone. It's such a complex structure, an interesting structure, anatomically so important in the face and function. And so I got interested because of Ian McGregor's work on periosteal stripping, and the fact that he reckoned that was a good way of telling whether the bone was invaded, but he hadn't actually found out whether it was any good. So my original reason for starting the thesis was to look at periosteal stripping. So what I did was, when we took a jaw out, and I worked in the West Midlands, so I was all over the place, I would take the bone and I'd strip the periosteum and predict what I thought, how much invasion was there, whether it was invaded or not. Number one, like this one, is not invaded. And if it was, to what extent? And that was very accurate, and the most accurate. And then I added imaging and everything onto that, and I'll come to that. But their understanding was not as good as Slutweg and Muller, who publishing at a similar time, 1989. And I thought that's what they had, this erosive pattern where you have a connective tissue layer between the tumor and the bone, and then when it becomes infiltrative, it just gets into the bone. It's all over the place. And I noticed that this tends to be deeper tumors, but you can get an infiltrated pattern straight away. And I think there's some interesting elements, perhaps my colleagues might want to look at, in terms of why patients have a tumor which tends to spread in bone more than others. But that may be for another day. But certainly that would be something I'd be interested in if I was still hammering on. So then you see, Ian McGregor said that it went down the periodontal membrane. The tumor went preferentially down the periodontal membrane. Well, it doesn't. What it does is it invades the jaw where it hits the jaw, no matter where it is. And I remember Julia said to me, well, she confirmed that for me. She said, well, just say that then. And so that's what we did. And you can see that this tumor is just coming into the attached and reflective mucosa, but it's just hitting wherever it does. And I remember I presented at Edinburgh, and Ian McGregor, who was a famous surgeon at the time, said to me, I disagree with just about every word you said. And I sort of thought, well, I wish he could be a bit more specific. And I was thinking, if he's really going to disagree with me, he should rubbish my method. But he didn't. And so I think, and of course, in McGregor's case, he didn't have any dentate cases at all. He was in Glasgow. In Scotland, they tend to lose their teeth fairly early in life. Anyway, at that time. And then I looked at imaging, and all the images were not as good as periosteal stripping. And of course, it's still quite difficult to tell whether we should do a rim or a segment, and that there's ongoing work on that. But that's also what I was trying to unravel, if you like. And then I started working on the mandible in some ways, because I did a lecture in Kuala Lumpur at the request of Lancet Oncology to give a talk. And so I thought, well, I'll talk on mandible. I've done maxilla. And I found some interesting things, some really interesting things. And one of the things I found was that Erkin wrote a fantastic, Mark Erkin, a review of mandibular reconstruction in 1991, and there hadn't been anything really decent written since. And I thought, well, look, I'll do it, now from that. And so I reviewed the literature. I did a systematic review. And I showed that the fibula, if you look at this, is 90 to 95, 96. Here's the whole period, 1990 to 2015, the 25 years, 65% are fibulas. But I can't see these other numbers. But basically, when you get the failure rate, you've only got 4,738 compared to 6,178. So an awful lot of series don't even tell you what their failure rate is. And the next one is the osteotomy rate, and it's very similar. So that was something that we noticed, especially Andrew Shackey noticed that. And he said we should really emphasize that and try and show, and 15% for iliac crest, that's been fairly steady over the time. And the same for radial forearm. Oh, God, it's working now. And at scapula, it has been done over that time, about 8%. And serratus and rib, but that doesn't really matter. And we thought we should have dental status, the side and the length, the defect, the reconstruction method, the osteotomies, early, late complications, and outcome. That's the minimum of what you should report if you're going to report your series of mandibular reconstruction. And I can tell you that wasn't very common. And then I wrote similar to the maxilla, I wrote a classification of the defect. And I must thank Richard Shaw, especially, and Andrew Shackey for making me put in this fourth class. I was only going to have 3 classes, and they said, well, you've got to talk about a really big resection. I mean, he said, what he said was really good. He said at one point, well, look, if we're not even going to use it, who's going to use it? And so I think you've got to, I learned a lot doing that. And I'm so grateful for them forcing me into the thing, because of course I'd done all the work and I thought I understood it and I thought I'd got there. But you've got to hear and listen and work. So that was a really interesting experience for me and very important. And that was my mandible. Now I'm going to talk a little bit about reconstruction in general and various things that I did, and about seven papers, and they're all quite varied and different. The first one I wrote was on the use of a superiorly based pharyngeal flap in addition to a radial forearm flap for soft palate reconstruction. And because my senior colleague wasn't using the technique, we were able to make a comparison of cases. And there was days when we did more surgery in soft palate than we do now. Obviously with HPB and radiotherapy, you get much better functional results. But we got pretty good results this way. And Annette Zidem, who was our speech therapist at the time, did fantastic work in assessing the way that these soft palates worked, which I'm very grateful for. And I did a paper on T2 tongue reconstruction and on the role of steroids in the healing of microvascular anastomosis, high-dose steroids. That was Peter Ward Booth's idea years ago when I was in Sunderland, and probably why I got that job in the West Midlands. But I tell you what, animal study work is very hard. The animals get sick, and it can be difficult. And really, what I should have done was I should have had a study model that had a failure rate built in, because of course all my anastomoses worked. So I couldn't say that the steroids did any harm. And then what I did was I counted the polymorphs and their palisading and compared that. And of course there was less with steroid. So it was likely that steroid probably helped, but of course I couldn't really confirm. And then in Liverpool itself, I published on salvage techniques and on reconstructive techniques, because we did a lot. And they're quite reasonable pieces of work and set a standard, I think. David Vaughan, I'm grateful to him. He set many standards. I mean, his quality of his reconstructive surgery was phenomenal. And he was able to make everything work and then report very high quality series, which sets a standard that we all work to now. So he takes a lot of credit for that, I think. And then with Simon Rogers, of course, one of my colleagues, and his quality of life work and outcome studies, I looked at soft palate and tongue. And of course, with the tongue, with a higher level of a tongue resection, 3/4 of total tongue, you get a much worse result in terms of speech and swallowing than a similar having to remove the soft palate. But we knew that, but it was nice to confirm it and to get that. And that was all questionnaires with patients. And again, it's just work that I got myself involved with. And then I eventually wrote a scapular series, you see, 2010. And it's a flap that I think is a great flap. And this case here is from the paper, and it's probably Richard Shaw's case of osteoradial necrosis, which can be a very debilitating condition. Well, you can hear about that next time, the radiotherapy. So what about how I'm going to finish? My last sort of comments about outcomes. And this paper is written by Simon. And it's a very highly quoted paper, 318 citations. And it's simply from 92, when I came to Liverpool, it's what happened to our patients, whether they lived or died. And we looked at all the elements, you know, the P stage, the PN, and extracapsular spread being a very important part of prognosis, margins, you know, the surgeon's thing on your shoulder telling you that you didn't take enough out. But of course, I think the margins are related to how bad the cancer is. But anyway, and we had all that data. But while that paper's 2009, and when we got this data, what I found, what really interested me was that postoperative radiotherapy didn't seem to be working particularly brilliantly, I thought. And so I thought I'd look at it. And that was this paper written in 2007. So a couple of years before we actually eventually published our series, the same data I used for this patient group. And I tried to look at low risk, intermediate risk, low risk being early stage, N0 and clear margins, and intermediate, NEN, but no involved margins. And then of course, high risk are extracapsular spread or an involved margin, but any, and you can see that postoperative radiotherapy was hardly used for any of the low risk, 0.7%, 41% for intermediate, and 81% for high risk. So that sort of figured out. And when we wrote this paper, we tried to do a sort of probability indication. We tried to bring the group a little bit closer by excluding patients that obviously didn't have radiotherapy and excluding patients that definitely would have it. So at each end, we tried to do that. And you see that in group A, the radiotherapy is 2 out of 28. It's very low, 7% compared to 90-odd% for the group D. And we looked at the PN plus and the close margins and the unfavorable pattern, and they all got more as it went across. So we looked at the 86 and 54 and compared it to the whole group, but there wasn't a lot of difference. Radiotherapy didn't seem to be helping them either way. And so Connor, I know he's here because I've seen him, Connor Barry, went to Australia, and he met Jonathan Clark, and we decided to bring our cases together and do a case match study. Because I couldn't get any money to get a randomized control trial. So that was the best we could do. So we took the intermediate risk, and you can see that they're very closely matched. For instance, PN 30 in each group out of the 45 and 15 with PN1. So it gives you an idea. They're pretty closely matched group. And the problem is that this was the main point of that paper, which was that intermediate risk of which was the of loco-regional recurrence. That was 0.039. P equals 0.039. But the thing about it is, if you're not giving radiotherapy, you've got more options if you get recurrence. And it isn't about whether you get recurrence, it's about whether you get uncontrolled disease, in my view. And the conclusion in this paper, I couldn't get changed, but very good loco-regional control with port, 84% compared with surgery alone, 60%. So you should give them radiotherapy. Well, I don't agree. And the reason I'm saying that is because it's not about whether they get recurrence, it's about uncontrolled recurrence. Because the decision not to give radiotherapy means you've still got it in your back pocket. So it's a bit like, well, I'm not going to, I haven't got really a lot of time to go into that, but I did have an analogy I was going to go through. But as you see, the disease-specific survival is identical. So when a patient comes to get postoperative radiotherapy at intermediate risk, you can say to them, and they say to the doctor, and what happens if I don't have this treatment? Well, you don't live any less time. You live the same length of time. The risk of not having radiotherapy is that you may get recurrence and then have to have further treatment. Now, whether that works out or not is fairly equivalent, whether you had radiotherapy first or second. And that's how it should be said. But it isn't. But anyway, I just wanted to make that point. And then I got Derek, what a fantastic guy. So to prepare this lecture, I said to Derek, could you look at the stats in this paper? This is the Conovari paper. And you can see that the 7 out of 45 and the 15 out of 45 is not significant with Fisher exact. It's 0.09. And the salvage attempts were more in the surgery group, which you would expect. And this is what I would say we should have been saying. And the successful salvage was higher, 47% versus 29%, if surgery alone, of course. And that's much bigger in our own Liverpool data. And then uncontrolled local and regional recurrence is the measure that we should have been talking about. And that's 5 out of 45 if you have port and 8 out of 45 if you don't. And there's no significant difference. And at the end of the day, we need a big group. 45-inch group's a small group. So the conclusion on this paper should have been that there's very little evidence to show that radiotherapy is of any benefit for this patient group. I've said it now. Anyway, I'm finishing now, but I never liked cycling. This is Tour de Misery 2013. For those of you who don't know, the Fred Whitten Challenge, and we took 2 days to do this ridiculous ride. It nearly killed me. Anyway, and then what happened was I fell off my bike. And Andrew's already alluded to that on my way to work to Warrington. That's the bridge over the Massachusetts Canal. It was I just crossed the Latchford Lock area and came off my bike. I don't know what happened. No idea. But the reason I'm saying that is because I had to go part-time and I changed my practice. I stopped doing head and neck cancer. And I'm still a bit mad because I wrote a paper called The New Classification of Mandibular Fractures. Because I gave a lecture to juniors and I thought, I know a little bit about classification. I thought I'd look on trauma. And I went to mandible and there was a lot of problems, I thought. So I wrote this paper. And basically, into the different classes, what is the commonest mandibular fracture? Of course, if you're not a maxillofacial surgeon, this bit of the talk might be a bit wrong, but what is the commonest fracture? Is it a class 2, which is an angle and a ramus? Or is it a class 2 and a condyle? Or is it a body, parasymphysis, symphysis in the middle? Or that sort of fracture with the condyles? No, it's a class 4, which is more than one fracture, not including a condyle anywhere in the jaw. Well, I didn't know that because there's the figures. 29% are 2 fractures not involved in the condyle. So I thought we should classify and make sure, but the trouble is in the literature, what happens is people just put in the number of fractures and it's not related to a patient. You'd be surprised, but that's what they do. So that's how I've gone on to do these things. So I could have done some things better. I would like to have played field hockey for longer. Achilles, give me. Liverpool FC had never won the Premier League. Well, they have now. When I first made this lecture, they hadn't. And I never got a randomized trial for patients receiving port. And tried to get my colleagues to use the Somerset Cancer Head and Neck Database as a routine in their clinics. Failed. My heroes, to finish. RB, Raymond Burton, headmaster at Talent School. Kanga, Mr. King, second master. Fantastic people. I was so lucky to be there and to remember them. And then Murdo, who taught me chemistry, and David Kennedy, maths and physics at Fetties. And Roger Brown, the oral pathologist at Birmingham, who was my MD supervisor, fantastic guy, and so helpful to me. And then Mark Erkin and Ralph Gilbert. I have to say that the reason I picked them out is because they're ENT colleagues, but they really got into reconstruction and changed things dramatically in their parts of the world because it's very plastic orientated. And I think they have been very good friends to me and great colleagues. And also, of course, all my colleagues. Thank you very much. You know, you've been great. And I'm so impressed at Liverpool, how it's gone on and left me miles behind. Now they get proper money and they run proper trials and they're fantastic. And to see that happen is wonderful for me to watch. So I have to say that. And just a little bit of a laugh with my new boyfriend. You know, he told me to bring my swimming trunks, and you can see why. But you know, this was us in the Andes. We went to Santiago. Santiago. And then we had some Americans there as well, and that was very funny. And then this is me operating. You know, I'm very fortunate. I've been all over the world. This is Bangkok at the dental hospital, doing a massive jaw, which I did a hip for, and I was a bit knackered at the end of it, I can tell you. And we saw this picture before, and I did the painting. This is a watercolor. It struck me just quite a good picture with all the heads and everything in there. And actually, that's what I was going to do when I retired. I was going to go in and watch them do a hip and take loads and loads of pictures, and then do a painting. But the trouble is, I'm not allowed in the hospital at the moment. Yeah. So anyway, this is my family. And of course, I have dental tag as well, and yeah. And so, in Nullius and verba. So what are we doing? We should challenge, and we have a way of doing it. So we listen carefully to an alternative view. You know, think about it. Don't be too arrogant. Try not to be, and you could be wrong, of course. So thank you very much, everybody.